Good morning, everybody. I'll pick up the ends of the thread from where Dr. Puneet has left, because to take any patient across the surgery safely, it is absolutely important that the surgeon and the anesthetist are absolutely on the same wavelength. So I'll begin by addressing this question. Why do we need to assess risk at all in a surgical patient? So that we can identify the risk factors, we can optimize and preemptively take corrective measures for preoperative patient physiology, the anticipated critical intraoperative events, and ensuring a safe postoperative course, and all this translates into an improved outcome. It also helps in triaging the utilization of critical care resources for postoperative care, which means assessing which patient is likely to warrant and benefit most from postoperative ICU care, especially because critical care resources are precious and cost intensive everywhere. And equally important, it helps us in appropriate patient counseling and taking informed consent. Dr. Puneet gave you a very good example of using the scores. Now, if you look at the literature, it says that surgical adverse events that have resulted in most complaints and litigations have been related to post-operative complications, post-operative deaths, unnecessary surgery, injuries related to equipment malformation, burns because of diathermy or thermal blankets, retained foreign bodies, and surgery-related infections. So if you look at a surgical patient's journey through the hospital, the exposure to risk is not only during the surgical procedure, but also during numerous processes and procedures that this patient has to go through before surgery, during surgery, and after surgery, which means the perioperative radiological investigations, any endoscopies if needed, blood transfusions, and n number of medications that this patient is going to receive. A simple real-life example, recent one, a baby with imperforate anus with a colostomy admitted from the OPD for an elective surgery for pull. Taken to radiology for a barium contrast study. Barium is injected under pressure. There is a colonic perforation in radiology. Patient has to be taken up for an emergency surgery for barium peritonitis. And the elective surgery for which the baby was actually admitted gets postponed by another 6 months. Now, the parameters that determine surgical risk can be divided into two broad groups. Those that are related to the preoperative patient physiology and associated comorbidities, and those that are related to the actual complexity of the surgery and the intraoperative events. So what are the parameters related to preoperative patient physiology? Dr. Puneet has highlighted the ASA and the NYHA. Extremes of age, both newborn, especially preterm and low birth weight, and elderly, because each of them have restricted physiological reserves and have increased risk of sepsis, malignancy, impaired nutrition, very important, associated organ dysfunction, which may be related to the primary surgical diagnosis. Example, a patient of chronic liver disease who warrants surgery for portal hypertensive bleed, or it may be unrelated but incidentally associated with the primary surgical diagnosis. Say a baby born with esophageal atresia needs emergency surgery for the same, but also has a VSD-PS pathology, which is a well-known common association. Immunocompromised state, post-chemotherapy or prolonged steroid therapy. Example, a steroid-dependent ulcerative colitis needing proctocolectomy, wherein every suture line will be precarious, including the abdominal closure, and increased risk of sepsis. Then what determines the complexity of surgery and the intraoperative events that may affect the outcomes adversely? One is the urgency of surgery, which in order of risk have been graded as immediate. So what does the term immediate imply? That there is absolutely no window period to resuscitate and optimize. Example being a patient with life-threatening torrential leak, blood pouring out from the nasogastric tube from the rectum, or a baby who has aspirated a foreign body and is desaturating. And this is one scenario where very often you will have to counsel the family that we may actually lose the patient on the table. Then urgent, wherein the patient will permit you a narrow window period of 4 to 6 hours to carry out the basic fluid and antibiotic resuscitation. Example, post-endoscopy esophageal perforation, severe mediastinitis. Expedite, wherein you can stabilize overnight. Example, subacute intestinal obstruction, and elective. So then why is immediate and urgent surgery associated with greater risk? Because the pathology does not give you enough time to optimize physiology, or optimization may not be possible as long as the source of sepsis is there. And here the patient is very often wheeled into the theatre with impaired perfusion, impaired oxygenation, incorrected metabolic milieu, and that is why Dr. Puneet said that if you handle patients with ASA grade 3 and 4, you are paid higher. Now, the others are duration of surgery and blood loss. And regarding blood loss, I would say that as a surgeon and also for the anesthetist, the most difficult scenario is one in which there is an inadvertent major vascular injury in what was anticipated to be an uncomplicated elective surgery. Example, straightforward laparoscopic cholecystectomy, aortic injury while inserting a trocar, or a slipped cystic artery clip. This is the worst situation because the team was not prepared for this. The vascular access may not be geared for large volume rapid infusions and the blood may not be arranged. And this was a study which was published in the year 2011 in Surgery. It was conducted under WHO's campaign of Safe Surgery Saves Life, and Dr. Gavande was a corresponding author. It says that an estimated blood loss of more than a liter, a lowest mean arterial pressure of less than 40, and lowest heart rate of more than 85. This is a study of adults only. It correlated with increased incidence of surgical site infections, unplanned re-explorations, sepsis, need for ventilatory care more than 48 hours, and pneumonias. Then the complexity of surgery is determined by risk to adjacent vital structures. Example, a large retroperitoneal tumors, every branch of the aorta needs to be safeguarded and dissected free. Reoperative surgery, always a challenge because of adhesions and loss of tissue planes. Difficult abdominal closure may lead to abdominal compartment syndrome and cardiorespiratory compromise. The anesthetist will not be able to extubate. Example, necrosectomy for pancreatitis or after a surgery for intracutaneous fistula where there is loss of tissue from the anterior abdominal wall. So after having assessed the risk, we come to the management because that is the reason why we do risk assessment. So WHO surgical safety checklist needs to be followed universally. But in addition, I would say that it is a good idea to create checklists which are individualized for every patient and every procedure. And why are checklists helpful? Because they make sure that no important issues for that particular patient are missed out and that every person in the team is aware of the entire plan and knows his or her role. And that is what Dr. Gavande says in this book called Checklist Manifesto. So this is a checklist that I would say that we would be following in a preoperative patient. Confirm diagnosis and if necessary reconfirm. Review radiology, review histopathology. Review radiology for the site and site of pathology. Vital structures which need to be safeguarded. Identify anatomical variations if any. Review histopathology, especially malignancy, with histopathology reported from another reference center. Especially when the proposed surgery entails removal of an organ, a mastectomy, a gastrectomy. Optimize physiology and metabolic profile, coagulation, nutrition. Nutrition, not only albumin and hemoglobin, but also things like magnesium, calcium, phosphorus, B12 because they are very important for perioperative recovery. Incentive spirometry for every patient who is going to undergo a major surgery. Sometimes preoperative intervention radiology to drain obstructed systems helps in optimizing physiology, say a PT-BD for high bilirubin, and that is why Dr. Rajnikant is such an important part of our team. Actively screen and treat for any lurking foci of sepsis, immunocompromised patients. Actively look for mucocutaneous fungal infections. If there are any tubes and drains in situ for a long time, send cultures, they will guide your perioperative antibiotics. Take preemptive measures to prevent surgical site infections. A good bath to the patient a day prior to surgery is such a simple act but it goes a long, long way in decreasing the incidence of surgical site infections. And then the right time and the technique of part preparation. Take a careful drug history, especially of drugs that will adversely affect the intraoperative course, particularly the anticoagulants, where you will need help of Dr. Aditya and Dr. Puneet. Confirm availability of intraoperative logistics, whether you have the right blood group available in the blood bank, whether the patient has a rare blood group, you need to reserve the blood beforehand. Special equipment that will be specific for the surgery. Energy devices, not only diathermy, but whether you need to use harmonic or APC or CUSA for that. Patient staplers, what size, which ones. If intraoperative frozen section is needed, inform the pathologist what specimen, what are you looking for. If intraoperative ultrasound is needed, inform the radiologist and reserve an ICU bed if postoperative ventilation is anticipated. Plan and discuss the crucial steps of surgery with the surgical team and equally important the anesthesia team. Planning the incision especially becomes important when it is reoperative surgery and you need to enter from the virgin plane. Otherwise, sometimes it may take hours to enter the abdomen itself and go through a recap of the vital structures that need to be safeguarded. Essentially, the purpose is that everybody needs to be on the same wavelength. Now, this is a WHO checklist. Dr. Puneet has covered the part which is before induction of anesthesia. Before skin incision, it says that all team members, the anesthetist, the surgeon and the nurses, they identify themselves by their name and by their role. They identify the patient, the procedure and the site. Then there is a review of anticipated critical events, the surgeon about any difficult steps of the surgery, the estimated duration of the surgery, the estimated blood loss, the anesthetist about what are the specific concerns anesthesia related for that patient, and nurses about the sterility of the equipment and fact that all the equipment that is required is functioning properly. Antibiotic prophylaxis, whether it has been given in the last 60 minutes or not, and whether the imaging is displayed in the OT. And to this I will add that please take appropriate steps to prevent hypothermia, use thermal blankets, hotlines, not only for children but also for adults, because hypothermia is one single factor which is a predictor of a lot of perioperative morbidity because of acidosis and cardiovascular respiratory depression. Now this bold red line is actually for the surgeons in the audience. Intraoperatively, please remember that the anesthesiologist is the captain of the ship, not the surgeon. And I want to say this because in the audience we have young and dynamic people like Dr. Anand and cardiac surgeons and endocrine surgeons, and then there are gray-haired people like me and Dr. Anu. And I'm so happy that Dr. Puneet is here because he will understand what I mean. So communicate to the anesthetist immediately if there is any unexpected blood loss, any change in your surgical plan because of which the duration of surgery may become prolonged, when you're dissecting around the airways, or if you're going to do any maneuver which will change the hemodynamics suddenly, like cross-clamping the IVC. Your anesthetist is your best friend during the surgery. Now, before signing out, the WHO checklist says that the nurse should confirm the name of the procedure recorded, the count not only of instrument but also sponges and needles, the labeling of the specimen, and the surgeon and the anesthesia review the post-operative management plan. And to which I will add that before signing out, check hemostasis and normal blood pressures. This normal blood pressure needs to be underlined if you want to avoid a sleepless night, both the surgeon and the anesthetist, because of a reactionary hemorrhage, because the pressures will rise when this patient wakes up. Label all tubes and drains properly, especially the chest tube drain. I think all of you will come across this kind of a situation that next morning the ward attendant may just go around emptying all the drains, and the chest tube is also emptied without clamping and without filling saline in that bottle. And you will get a phone call from the ward that a patient who was stable half an hour ago suddenly has acute respiratory distress. Now, there's some messages that are beyond the checklist which I want to give to all of you across all specialties on behalf of all of us. Communicating well is one very important factor that reduces errors. Communicate well with every member of the team, whether the surgeon, the anesthetist, the intensivist, the nursing staff, the radiologist, starting from the junior-most resident to the consultant. Actually, the junior-most person is the most important person of the team. And if we can communicate with the patient and the family in an honest and in an empathetic way, especially when there has been an adverse event or a need for re-exploration, believe me, 99 out of 100 times, the patient will be supportive, and not only supportive, he will leave the hospital with a word of gratitude towards you, especially in India. And for any intervention procedure, never hesitate to ask for help. If there is unexpected bleed, an inadvertent injury to any vital structure, say bile duct or ureter, because any intervention procedure, mishaps will happen in each of us, in the hands of each of us, even in the best of hands, and therefore asking for help at the right time is in the best interest of the patient, it is in our best interest. Then every unit needs to have an honest audit, the purpose of which is not to fix the blame. The purpose is to identify factors which are affecting our outcomes adversely, say a sudden spot of surgical site infections. Where is the breach in the asepsis in the entire cycle? and a targeted approach to rectifying them. And finally, about surgery, I would say that surgery is one specialty which has a much longer learning curve in terms of honing of surgical skills, in terms of right decision making, and therefore mentoring in surgery in the initial parts of the training goes a long, long way in reducing errors. And with that, I sign out and hand back to Anand, and I thank all the physicians for listening.